If you're just joining us now, welcome to our webinar this evening. If you're new to EOS Network, welcome for the first time. If you're returning, welcome back. Just so you're aware, our mission is to ensure that everybody with eosinophilic associated disease receives a prompt, accurate diagnosis, cohesive medical care and support to live with their condition. A big mission. This evening, we will be talking about HES and EGPA. And we're delighted to welcome Florence Roufosse. She's Professor of Medicine, Internist and Clinical Immunologist at the CUB Hospital in Brussels.
Okay, so well, first of all, I'd really like to thank Amanda and the EOS Network for giving me the opportunity to talk about these two rare disorders. I think that's really important to really be conscious that this is, we're talking about orphan disease here, but I think it's really interesting. And I mean, I've been caring for patients with these two diseases for 30 years now. And with the development of new therapies, I have seen an enormous change in awareness about these disorders. We all know how orphan conditions can be, but I think that there's clearly a level of knowledge which is progressively increasing amongst healthcare providers, and it's actually changing the way these diseases present in the clinic. Earlier and earlier now. So I'm going to give you an overview of these two diseases. It's pretty difficult to do that in 40 minutes. So I've really tried to choose the essential things, and obviously I'd be very happy to discuss further when I finish this more formal presentation. There we go. So I'd like to start, I mean, this is obvious, this is an obvious one, but I'd just like to start by talking a little about eosinophils, because it's very important to understand exactly how this cell behaves, to be able to understand the potential severity of these diseases, the importance of recognizing eosinophils when they're present at increased levels in a blood count. It's so easy, you know, some diseases are really super difficult to diagnose, and here we have a very, very common thing which is found on most blood tests, which is the complete blood count, which is really a major hint to making this diagnosis. So a few words about the eosinophil to begin with. What you see here on the left is, I'm just going to perhaps try to take my laser pointer if I can. There we go. Okay. So this eosinophil to the left is an eosinophil in a blood smear. It's amongst a series of red blood cells, and here what you see on the right are eosinophils in tissue. And what you can see immediately is that the cell is really easily recognizable, and I think that's a first very important point. As I said, eosinophils are so easy to pick up, whether it's in blood or tissue, because they're packed with these little granules that you can see here. And these granules, we're going to talk about them immediately afterwards, but they contain extremely basic substances, and basic, I mean high pH, meaning that they have an enormous affinity for the dye, which is called eosin. And whenever we do a blood smear or a tissue section, when we do biopsies, we stain with hematoxylin and eosin. And eosin is very acidic, and you know that acids and bases have a very, very strong affinity for each other. So this is why we see eosinophils so prominently with these routine stains, no special stains necessary. Eosin really likes eosinophils and vice versa. That's why they're actually called eosinophils, by the way. So you can see the eosinophils here in the tissue. They're infiltrating the subepithelial region, and we'll talk about tissue eosinophils just in a couple slides. Okay, so where do eosinophils come from? These are white blood cells that begin their life cycle in the bone marrow. And they actually developed under the influence of a series of factors in the bone marrow. And the most important factor, which is really specific for the eosinophilic lineage, is interleukin 5. This is a cytokine whose receptor is expressed on the surface of the eosinophil, and it's one of the only cells in the human body that express this receptor, and certainly the cell which expresses the receptor at the highest levels. Once it's developed in the bone marrow, it's going to enter the bloodstream. And eosinophils are cells that actually appreciate moving and migrating towards tissues. And so that means that roughly the majority of the cells that we have in our body of eosinophils will be found in tissues. And it's why in the peripheral blood, they only represent 1 to 5% of the white blood cells. And usually we prefer talking about absolute counts of eosinophils, because if you have a cell type which is poorly represented, if the other cell types which are more, proportionately more present in the blood decrease for a series of reasons, the percentage of eosinophils is going to increase, but it's just a relative increase compared to the other cell types. So what we really look at is how many cells are there per microliter, per millimeter cube, per liter. There are loads of different units, whatever we want to use, but we really look at absolute counts to make sure that eosinophil counts are normal. As I said, they migrate to tissues. You can see the tissues where eosinophils are generally found in healthy human beings, healthy mice as well, by the way. I won't be talking about eosinophils in mice today, but many functions of eosinophils have been studied extensively in mice, much less so in human beings. And because of the enormous surface of our gastrointestinal tract, the majority of our eosinophils are actually found in the mucosal surface of the gastrointestinal tract, with the exception of the esophagus. In the healthy state, there are 0 eosinophils in the esophagus, because as of the stomach, you're going to find increasing amounts of eosinophils until the cecum, and then the amounts will decrease again. Eosinophils, as I said, are packed with granules, and these granules have different shapes and sizes. They also have different contents. Typically, the contents of eosinophil granules are going to be these highly basic proteins that I mentioned, which are responsible for the staining properties of this cell. These include major basic protein, eosinophil peroxidase, eosinophil cationic protein, and eosinophil-derived neurotoxin. But as you can see, eosinophils produce many different substances. I'm not going to go through this in detail. This has absolutely no place here. They also produce a series of mediators which are derived from arachidonic acid, which is found in cell membranes. And these mediators also have a series of effects on the body. For example, they can cause bronchoconstriction, which is typical of asthma. They can cause vasodilatation, which is going to be responsible for swelling, for example. Many of these substances are going to be released from the eosinophil in different circumstances. So depending on what's in the actual environment in a tissue, the eosinophil is going to receive different messages from this environment, and it's going to behave differently. So eosinophils are quite plastic in their behavior and are modulated by their environment. An important mediator which is produced by eosinophils is the galectin-10, and this is actually produced almost only by eosinophils. And which is one aspect that is really specific to eosinophils is that when they release galectin-10, it's going to crystallize in the environment and form what's called Charcot-Leyden crystals. And if you find Charcot-Leyden crystals in any human body fluid, that means the eosinophils were present there recently in that tissue, in that organ or whatever, and have degranulated. They've released this. And I have no time to discuss this today in the setting of this session here, but Charcot-Leyden crystals are extremely toxic. They really participate, for example, in some of the very, very severe aspects of eosinophilic asthma. What's known about eosinophil functions? So there's really a kind of historical thinking that eosinophils were really final effector cells. In other words, they receive messages and then they behave always in the same way. And this behavior is always causing cytotoxic damage. If you want to look at it a kind of finalistic way, eosinophils were developed and they exist so that we can destroy large parasites. You may know that bacteria are very, very small. These are single cell organisms. So we can actually destroy them by engulfing them in cells, in white blood cells. We can swallow them up by white blood cells. That is absolutely impossible with a parasite. Helminths, so helminthic parasites, these are what you could also call commonly worms. Their larvae are already gigantic, and the worms themselves as well. And so we need to have cells which are equipped, once they recognize the larvae, to release the substances on the surface of the larvae and kill it. And that's what eosinophils do, and that's why they're so mean, so invasive, so toxic when they invade a tissue. And it was already known from long ago, and I'm going to just do this animation right away. The eosinophils participated in the pathogenesis of asthma. What you see here is on the left, it's a healthy human bronchial surface, and on the right, it's the bronchial surface of a patient who has asthma. On the left, you see that there are very few eosinophils. These eosinophils actually have been stained for eosinophil cationic protein. They appear here as brown cells. They're not very numerous, and they're well below the epithelial surface, which is shown here. It's a bit darker up here. Whereas in a patient here with severe asthma, you can see that the eosinophil numbers have increased significantly. Some of these eosinophil-derived granule proteins are actually no longer intracellular. They've been released into the tissue, causing cytotoxic damage, which you can see here. If you look at the structure of the epithelium, it's no longer recognizable as a healthy epithelium. So this is really, these are historical studies from the 1990s showing that eosinophils clearly played an important role in human asthma. And once again, I have no time to go into any great detail, but we can discuss this if it's of interest to anyone. But eosinophils really participate through these cytotoxic effects in a series of pathological aspects of disease in human beings: mucus plugging in asthma, remodeling and fibrosis in asthma, but also in other disorders. Epithelial damage, we've already seen this, emphysema, neural dysfunction, etc., etc. So eosinophils have a series of substances and properties that are highly damaging to their environment. What is hypereosinophilia and what is hypereosinophilic syndrome? So now just a couple definitions. Hypereosinophilia, that's the first step. When does a patient have hypereosinophilia? It's when in the blood there are at least 1,500 per millimeter cube. So I showed you before that the upper threshold for normal eosinophil count is 450 to 500. This is above 1,500. So you can see that there's a kind of gray zone between the threshold for normal eosinophilia and what's called hypereosinophilia. And that's because lots of people who have simple allergies like hay fever or whatever, their eosinophil count can be slightly elevated. It can be 700, 800. And that's not going to trigger a series of investigations to see if these patients are in danger of having damage caused by their eosinophils. So getting back to numbers, we need to have more than 1,500 to be able to define hypereosinophilia. And between hypereosinophilia and the norm, this is what we call eosinophilia, like we can see in presence of hay fever, for example. Tissue hypereosinophilia will be defined in different ways. I'll just perhaps summarize that by saying that the pathologist, when he looks at a biopsy specimen, just thinks there are way too many eosinophils compared to what he usually sees in this particular tissue. So you see that it's already a lot more dependent on the expertise of the pathologist. And maybe I can just slip in here that just today, I had a patient who had eosinophilic gastritis, had a second biopsy. The pathologist said, I don't see any eosinophils whatsoever. I did not understand this result. I sent it to someone else and it was packed with eosinophils. So even this step, which seems really easy, it's not that easy and straightforward. You have to have pathologists who are sensitized to what eosinophils look like and how to define them. I was very surprised by by what happened today. So what's a hypereosinophilic syndrome? This is when blood and tissue hypereosinophilia are both present, so more than 1,500 in the blood and too many eosinophils in a tissue. This presence of eosinophils in the tissue is causing damage or dysfunction to an organ, and we're going to see the different organs which can be concerned right away. So a patient who has hypereosinophilic syndrome will suffer any amount of signs and symptoms related to this eosinophil-mediated damage and dysfunction. For example, they can experience a breathlessness due to the presence of lung infiltrates, diarrhea due to the presence of gastroenteritis with infiltration by eosinophils, eventually heart failure due to the presence of eosinophils in the heart, etc., etc. In blue, I just put these boxes around the most common manifestations: lungs, GI tract, and skin. But as you can see, practically no organ systems are spared by eosinophils. And patients can have one manifestation or they can have numerous different manifestations, depending on where the eosinophils will eventually migrate in their own body. How does this disease develop? I think the biology behind this disorder is way too complicated to go into much detail here. But basically, going back to eosinophils developing in the bone marrow, there are two major disease variants which have been defined. The first one is it's when eosinophils are actually leukemic cells. This is very uncommon. What happens is there's a mutation that occurs in one of the precursors or the progenitors of eosinophils in the bone marrow. And just like any other form of leukemia, the eosinophils are going to start expanding from a mother cell, and it's all going to be cells coming from the same original mother cell. This is uncommon, but I'm going to illustrate one example. Another variant is when there's way too much IL-5. I said how important IL-5 was for eosinophil development, activation, etc. There is a disease variant called lymphoid variant hypereosinophilic syndrome, where it's well demonstrated that there's a particular type of subset of lymphocytes. It's another type of blood cell that produces IL-5, and this is driving eosinophilia. But this time there are many mother cells, so it's polyclonal hypereosinophilia. Very, very rare, very uncommon. I think there have been just a couple families described so far in the entire world. There can be mutations which are genetically acquired. They're inherited from parents with familial hypereosinophilia. I won't even be touching on that today because, as I said, I think there are 3 families so far which have been reported in the literature. And unfortunately, in the vast majority of patients, about 3/4, what is actually driving expansion of eosinophils remains entirely unknown. I said I was going to define these 2 variants very briefly. This is a complicated slide, but I just wanted to illustrate with a figure what's happening in patients who have this clonal mutation, which is causing clonal hypereosinophilia. There's a tiny, tiny little bit of chromosome on chromosome 4, which is deleted. It's so tiny that you can't see it on a karyotype. But what happens when this gene is deleted, so I'm going to put that here, this is the part of the gene which is deleted right here. It's going to make 2 distant genes actually combine and form a new gene. And this new gene is called the FIP1-like-1 PDGF receptor alpha fusion gene. I'm not going to go to any details, but at the end of the day, what happens is because of this new gene, the cells acquire the capacity to proliferate on their own. They no longer need any messages from the external world to proliferate, which is usually what happens for cells. They proliferate on their own. This is the barbarous name which has been given to this particular disease by the World Health Organization. And this anomaly, almost exclusively concerns men. And a very, very heavy hint that it may be present is when you have a patient who has hypereosinophilia that does not respond to oral corticosteroid therapy. That is so unusual. Eosinophil counts usually, if you give corticosteroids orally or intravenously, they will go down within hours. These patients, that doesn't happen. The other variant, once again, it's a bit of a complicated slide, so I'm just going to try to share really the concept. Eosinophils actually are not sick at all. What happens in this disease, it's T cells, it's lymphocytes which are sick. There's a particular subset of T cells which develops, is completely abnormal. It's called CD3 negative, CD4 positive T cells. These T cells are actually monoclonal. So it could be assimilated, let's say, to a kind of lymphoma, except that in these patients, the disease is not malignant. It's potentially pre-malignant in a very small proportion of patients, but they actually just have monoclonal T cells, which are producing loads of IL-5, and this is driving polyclonal hypereosinophilia. And this is generally a very typical disease presentation. The hypereosinophilic syndrome in these patients is very, very commonly limited to the skin or to the subcutaneous tissue. Patients either itch, have lots of skin lesions, and or they have angioedema, which means swelling. And sometimes the swelling is diffuse, sometimes it's patchy, sometimes it's lumps that come and go, but those are the most common clinical manifestations. And the way to reach a diagnosis, I think, is beyond the scope of this presentation. But once again, if there are healthcare professionals which are attending, I'd be happy to discuss this later on. I said that patients are very variable in the nature of the complications of their hypereosinophilia, sometimes one complication, sometimes several complications of disease in different organs. They are also highly heterogeneous with regards to how their disease behaves over time. In a small proportion of patients, they're actually going to do one flare, which is going to be treated, they're going to get better, and their disease is never going to come back again. This can happen quite typically with eosinophilic gastroenteritis. It's not what happens to all patients who have this variant, but some patients have a single flare in their life and it never comes back. Another form of disease is that patients have flares, they're treated or not, disease gets better, you taper down treatment, and then they flare again and again and again. And between flares, they're well. And then finally, the most common evolution, the disease course over time, is patients begin with a flare, you treat them with corticosteroids, start tapering the corticosteroids, and you can't. Their disease comes back. And at that point, they continue with low-grade active disease, and there's kind of a compromise between persistence of low-grade symptoms and toxicity of corticosteroids. And we'll get back to that a little later. There's always this kind of, this balance, and the balance depends both on the clinician and on the patient, what the patient is ready to put up with, on one hand, in terms of disease activity and symptoms, and what the clinician agrees to put up with in terms of risk, future risk for the patient. How do you reach a diagnosis of hypereosinophilic syndrome? I think really the first important point is to first exclude all the causes of hypereosinophilia. As I said, this is an orphan disease. Most patients with hypereosinophilia actually don't tolerate one of their medications or have a parasitic infection. They can have cancer. This can cause paraneoplastic hypereosinophilia. So the first step is really looking for one of these common causes of hypereosinophilia. An important step also, the next one, is to look for evidence of eosinophil-mediated organ damage. And this is going to be done through a series of tests. The tests will obviously be guided by the symptoms the patient has, but at minimum, there's going to be blood tests looking for liver problems, etc. So we're going to do routine chemistry. Also looking for cardiac damage and suffering, looking at serum troponin, for example. Imaging in the heart is super important because the early stages of heart disease in hypereosinophilic syndrome are generally clinically silent. So we're actually going to go actively look out for them. And then to be able to guide treatment and follow-up of patients, HCPs also have to investigate for those two disease variants that I mentioned. Even if they only account for about 1/4 of patients, if they're put together, it's very important in terms of therapeutic choices. So now moving on to the clinical presentation of eosinophilic granulomatosis with polyangiitis, which I'm going to call EGPA from now on for obvious reasons. This disease is a bit different in its natural course. What often happens is patients begin with asthma and sinonasal disease. So this is actually a disease that in its early stages concerns the airways, both upper and lower airways. And the sinonasal disease can be pretty nasty with nasal polyposis, chronic rhinosinusitis, which can really be extremely invalidating. And the asthma is generally adult onset asthma. Patients who may have had asthma in their childhood that got better with puberty, that's quite common, but then all of a sudden the asthma comes back at 35, 40 years of age, extremely severe asthma, nothing to do with what they had known when they were younger. And then there are patients who've never had asthma before and they develop it as an adult. The next step is development of hypereosinophilia. Patients will all of a sudden experience blood hypereosinophilia and tissue hypereosinophilia. And you can see here one of the tissues which can be affected by eosinophil infiltrates. This is eosinophils in a bronchoalveolar lavage fluid. And then the next step is vasculitis. This is the most severe complication of EGPA, where blood vessels are obliterated by very, very active inflammation of the vessel wall. And this obviously causes ischemic damage, necrosis of the tissue, which is dependent on those vessels to be oxygenated. I'm not going to go through this slide in detail. I believe the recording will be available for everyone, but once again, you can see just from a glance that very few organ systems, if any, are spared in EGPA. It's similar to hypereosinophilic syndrome. And if I just want to kind of summarize the kind of damage that patients will experience, it's a mixture of what we just saw with hypereosinophilic syndrome. So these patients can have eosinophilic infiltrates and damage more or less in the same tissues as a patient with HES. But there's also the vasculitic complications which kick in, like, for example, glomerulonephritis, so that's the kidneys, or alveolar hemorrhage, that's in the lungs, and it's really bleeding into the lungs because of vasculitic damage. I just kind of, I think, already showed you this notion that disease progresses stepwise. So first patients have asthma, then severe asthma, then blood eosinophilia develops, hypereosinophilia, then they develop vasculitis. And what's interesting, and we'll mention this in a few slides, is the presence in a subset of patients of what's called ANCA antibodies. I'll mention that in more detail in a couple minutes. But I think what I really want to underline is that there's significant overlap between these two diseases. In this article, where Mike Wexler is first author, we made a diagram where you can see HES manifestations in blue, EGPA manifestations in red, and everything that's purple is common to the two diseases. And you can see that there's really a lot of purple here. And then there are a few things which are more common, mostly in EGPA because of those vasculitic manifestations. Diagnosis of EGPA, very, very complex because there are no diagnostic criteria for this disease. For HES, I did show you that there's a kind of consensus on criteria for diagnosis. Here, there aren't any. There's only one thing which can help clinicians. It's classification criteria. So those criteria can only be used in presence of a patient who has vasculitis. And that's a patient which is really far along in the disease course, as I already mentioned. So you can use these criteria when you're already confronted with full-blown disease. And that still happens. You still get patients for whom the diagnostic journey has been extremely long and difficult, and no one has recognized these different stages of disease until they get vasculitis. And that's when the diagnosis will be made, thanks to the classification criteria. But we would like to make the diagnosis a lot earlier in disease course to avoid that irreversible damage. In the scoring system that can be used once they have vasculitis, asthma, blood hypereosinophilia, and nasal polyposis really weigh very heavily. That's what makes you get the score for EGPA. And once again, there's a series of tests that have to be done. Patients, because of the asthma, there's always going to be pulmonary function tests. There's always going to be an ENT check. There are always going to be blood tests looking for these serum antibodies. If present, they're very helpful for the diagnosis. If absent, the diagnosis is by no means excluded. And then a series of other studies, which will obviously depend on clinical signs and symptoms. Moving on to treatment, and as usual, I talk way too much, so certain slides I'm going to try to move rapidly to really highlight the essential parts. First thing that I'd like to mention for hypereosinophilic syndrome is if you have one of these clonal eosinophilic disorders, there's no discussion. This is for the hematologist, and the treatment is going to be Gleevec, and Gleevec works remarkably well. Even, I mean, here we're talking about chronic eosinophilic leukemia with perspective for cure. Cure means one day you can stop the drug and the patient will no longer have disease ever. So this is really amazingly effective for this particular patient population. The next patient population, I'm not going to go into detail. If the blood test shows other anomalies, which are highly suggestive of clonal eosinophilia, and there are other forms, but they're a lot less common than the one I mentioned to you, you have to send these patients to a hematologist for sure. They need to be entered in clinical trials. These are really, really tricky disorders. The majority of patients, so 3/4 plus the lymphocytic ones, that's 10 to 15%. So really, the majority of patients, first-line treatment is going to be corticosteroid therapy. And then second-line treatment is going to depend on their clinical presentation. And mostly, that's going to consist in hydroxyurea and interferon alpha. That's all we had until a couple years ago. And I'm going to show you right away that that was not amazingly good. All we had, because what I'm showing you on this slide is Among the patients, in a large cohort of patients, this was a multicentric cohort, there were 11 centers, almost 200 patients, and we retrospectively looked at the treatments they were receiving and what happened with these treatments. So you can see here in this, I think there were 188 patients. Of those patients, 64 and 46 had been treated with hydroxyurea or interferon alpha. And you can see the percent of patients that actually had to stop therapy. And why was this? Either it didn't work, in light gray, or because it was impossible to tolerate. So more than 3/4 actually had to stop these medications, which means back to square one, which means back to corticosteroid therapy. Now passing on to EGPA, conventional treatment before a couple of years ago. It depended here on disease severity and not on disease variant. Patients with moderate or mild disease, you can see prednisone, so that's corticosteroids for many, many months. Patients with severe disease received first immunosuppressive therapy, and then, let's say hardcore immunosuppressive therapy, and then maintenance therapy also with immunosuppressive agents. But these patients also had corticosteroids throughout their disease course from the beginning to the end. And the problem was for both disease variants, for both degrees of disease severity, is that as physicians taper down the maintenance corticosteroids, at one point, they're not going to be able to go any lower. And this is generally going to be because of the asthma and the ENT manifestations. Once again, exactly what I just said for HES. You're going to try to taper down therapy. You're going to try to give some other agent. And at the end of the day, you're going to be stuck with long-term corticosteroid therapy because there's going to be persistent disease manifestations. So that's where all the interest for trying to target eosinophils in these two disorders arose. Obviously, I think I've convinced you, I hope I have convinced you that eosinophils are really a key cell that drives pathogenesis in these disorders. So we know a lot about eosinophils, including the types of receptors that they express on their surface. I already mentioned this IL-5 receptor, and that's really the one that I'm going to discuss now until the end of this, this presentation. But you can see that eosinophils could potentially be targeted through different receptors. The only receptor which has really gone to the clinic so far is treatment which targets this IL-5 receptor. And that makes sense because IL-5 is really central in eosinophil biology. IL-5, I already mentioned its importance in development of eosinophils, but it's also important for activating eosinophils and favoring their degranulation. It favors their migration to tissue. It favors also their survival once they're in tissue. So if you have too much IL-5, you have too many eosinophils, they're too activated, and they're not dying. So targeting IL-5 really makes sense in both diseases. You can target IL-5 in one of two ways. Either you target the actual cytokine. So these are therapeutic antibodies directed against IL-5 itself. They're called Mepoluzimab and Benralizumab, or clinically, the commercial name is Nucala and Cincaero, and they're going to starve eosinophils of this growth factor, which eosinophils really crave. And then there's another molecule, Benralizumab, called commercially, this is Fasenra, which is going to not only prevent IL-5 from meeting its receptor here, but more importantly, it's actually going to attach to the eosinophil because it's attaching to the receptor itself and attract killer cells. NK means natural killer. It's going to attract killer cells, which are actually going to go out and destroy eosinophils wherever they are, in the blood and in the tissue. I'm going to first describe a few clinical trials for hypereosinophilic syndrome with agents targeting IL-5, the IL-5 pathway, and then I'm going to talk about EGPA. So the study which led to approval of Mepoluzimab for hypereosinophilic syndrome was published in 2020. In Belgium, we've been able to prescribe it since June 2022, if I'm not mistaken. In this study, patients had to have HES, which was not FIP1 like 1 positive, because those patients, they need to have Gleevec, that's it. And they had to enter the trial with uncontrolled disease, high eosinophil counts in the blood, and active symptoms. And then coming into the trial, they were randomized 1-to-1 to receive either Mepoluzimab 300 milligrams every 4 weeks or placebo subcutaneously. And this was done for, as you can see here, the last injection was at 28 weeks, and 32 weeks was the end of that double-blind placebo-controlled trial. And the thing here was, okay, they have active disease when they enter. When is going to be the first flare? What is the proportion of patients who are going to flare if they're receiving active treatment or placebo? And the trial reached its endpoint. This is the proportion of patients who flared. And you can see that among those receiving Mepoluzimab, 28% flared compared to 56% in those receiving placebo. This is a 50% reduction. You can see here in pink with Mepoluzimab, in dark blue with placebo, the flares as they develop over time during this 32-week period. And well, this was a 32-week study. If you annualize the flare rate to say, okay, how many flares does this make in these patients per year? It was a reduction by 66%. The annualized flare rate was 1.5 in patients with placebo, 0.5 in those who had received Mepoluzimab. So it was a successful trial. Going back to a more historical study, you can see here it was published in 2008, and we actually started enrolling patients in 2004. This was a completely different design. I'm not going to describe it in detail, but patients entered the trial with corticosteroids and they were stable. And this was a corticosteroid sparing study. And so we reduced corticosteroids during the study to see how low we could go and how long. Just here to mention in passing, the dose of Mepoluzimab was a lot higher. Patients received 750. This is 7.5 times higher than what patients who have severe asthma receive, by the way, every 4 weeks. And what's really interesting here, in the active treatment arm, half of the patients are aligned here on the 0 milligram line. These are patients who had to require more than 20 milligrams when they entered the trial. And you can see half of them were able to completely taper off. And the median dose at the end of the trial was 6 milligrams against 21 milligrams in the placebo. That's an enormous difference. It's very meaningful, both to patients and to their doctors. I'm not going to show this one. It's long to explain. I can come back to fatigue if you're interested. I'm sure some of you may be, but this trial just showed the impact, the positive impact of Mepoluzimab on fatigue in patients who entered the trial versus placebo. So the IL-5 receptor has also been targeted in patients with HES. This was a pilot study that was done by the group at the NIH by Amy Cleon. The aim of the study was to show that Benralizumab could decrease eosinophil counts in these patients who had enormous blood eosinophil levels, and it reached the endpoint successfully. You can see here compared to placebo. And the trial also showed, if you see before on top, after on the bottom, all these brown cells are eosinophils here. And you can see that in the GI tract of this particular patient, eosinophils had completely disappeared in these biopsies with Benralizumab. And there's currently an ongoing phase 3 trial called Natron, that some of you may have heard of, in HES with this same molecule. And this is really the study with which we are hoping to gain approval one day of Benralizumab as well for HES. So now, how would these different treatments fit in nowadays? I think the first step clearly is to make sure that patients are corticosteroid responsive. Try corticosteroids, try tapering it down to see what happens. I said that some patients have only one disease flare ever in their life. So I think you have to start with corticosteroids, but not for years and years, for several months. Taper them down, see what happens. And if disease comes back, this is already the point at which we should start considering these extremely effective and extremely well tolerated eosinophil depleting treatments. How about EGPA? I'm not going to make too much detail once again on the clinical trials, but this was the first trial in EGPA comparing Mepoluzimab to placebo in patients who had EGPA according to a series of criteria. We can also discuss that afterwards if some of you are interested. Anyways, the idea of this trial was to see how many patients entered remission. And remission was defined by two conditions: no disease activity and requiring at most 4 milligrams of prednisone. Knowing that patients who entered the trial, they required at least 7.5 milligrams. So as patients were able to taper down their corticosteroids, they entered remission. And you can see here that the remission was much more common and earlier in patients who had active treatment, and they relapsed a lot less during this trial. More recently, there's the MANDARA study, and this has led to, so this study led to approval of Mepoluzimab for EGPA. So Nucala is reimbursed for EGPA treatment, and it has been also in Belgium since June 2022. MANDARA is a different study in its design. It was, since we already had Nucala, we already had Mepoluzimab for EGPA, it was commercialized, approved, etc. It's not ethical to compare Benralizumab to placebo anymore because we already have an effective active therapy. So this was a very elegant trial. It's what's called a non-inferiority study. Is Benralizumab non-inferior to Mepoluzimab for inducing remission in patients with EGPA? That was the end point of the trial. It was the proportion of patients achieving remission towards the end of the study. And what you can see here, just at a glance, is that the height of these histograms is the same. Indeed, this was non-inferior. Benralizumab is this burgundy color here. It was non-inferior to Mepoluzimab for inducing remission in this patient population. So equivalent efficacy in terms of that primary endpoint. More efficacious in terms of lowering eosinophil counts, and that's related to its mechanism of action. Benralizumab, as I said, it goes out there and kills eosinophils. Mepoluzimab deprives them of a factor on which they are dependent, but sometimes in tissue, eosinophils find other factors which can help them survive as well. I talked about glucocorticosteroid sparing earlier on for the HES studies. The HES study, well, this is pretty similar. You can see here, perhaps on the left, when patients entered the study, MANDARA, this is at baseline, how much corticosteroid therapy did they require? You can see that the majority of patients required 15 milligrams, between 7.5 and 15 milligrams. That's the large majority of patients. The median baseline dose at study entry was 10 milligrams. And if you look at the Benralizumab arm at the end of the study, it was 1.2 milligrams. That's super low versus 3 milligrams in the Mepoluzimab. It's a great success, whatever the treatment arm. This is a significant decrease in background corticosteroid therapy. And perhaps the small difference between the two molecules is shown here. The proportion of patients who are completely tapered off corticosteroids was a bit higher, 41%, in those receiving Benralizumab compared to those receiving Mepoluzimab. And this is not because clinicians were seeing blood eosinophil counts, because we were blinded to that. So this means that the clinical control was such that clinicians were comfortable enough, as were patients, reducing further their corticosteroid dosing. I also just want to mention, in passing, that after this double-blind controlled non-inferiority study, which lasted 1 year, patients were allowed to enter an open-label extension study, which has been still going on. I still have patients personally in this open-label extension. Some, I think they're like 4 years into the open-label extension. And during this open-label extension, just a couple nice results here. I said that the remission at the end of the study was about 2/3 of patients who were receiving Mepoluzimab or Benralizumab. Here you can see Benralizumab in blue, Mepoluzimab in orange, and then everyone here, as of this more shaded part of the screen, was receiving Benralizumab, and you can see that the remission was maintained over this complete 2-year period. The next slide shows this was the difference in the proportion of patients who were able to completely taper off corticosteroids. You remember, 41 versus 26. When the Mepoluzimab treated patients were shifted to Benralizumab for the second year, they also reached this 43% patients completely off corticosteroids. Very briefly, during MANDARA, what was interesting is that patients were interviewed. They were interviewed twice, and one of the interviews, the first one, was done really when they were enrolled in the trial, and they were asked what their motivation was to participate in the trial, and also what their personal definition of treatment success was. I think that's really important. It actually had not been done yet in this field. And what you can see here is the proportion of patients who said, to avoid long-term side effects of oral corticosteroids, to reduce the corticosteroid dose. Patient definitions of treatment success, almost half wanted to stop, reduce using oral corticosteroids. So this is really a major incentive in general for patients who have these chronic inflammatory disorders, is getting rid of corticosteroids, which is causing a lot of side effects, a lot of poor tolerance, I think it's really important to keep this in mind. So the take-home messages I think that I'd really like to highlight after this presentation. I think I've shown how complex these diseases, and I only showed you a tiny corner of the complexity. The pathogenesis is extremely complex, but one thing for sure is it involves eosinophils in both diseases. They are both associated with significant symptom burden, and the longer disease lasts without being treated properly, it's going to be accompanied by irreversible damage, potentially, whether that be the heart, ischemic damage in EGPA, etc. Many patients are corticosteroid dependent. I showed you that both for EGPA and for HES. When you try to taper down therapy, at one point, disease is going to come back with symptoms. Reducing or stopping oral glucocorticosteroids are major incentives for patients. And we can now target eosinophils by targeting either IL-5 or its receptor on their surface. And this really enables reducing corticosteroid use while maintaining disease control. And I would even say, and this is not for 100% of patients, far from that, but I mean, certainly in HES and in EGPA, there's a significant proportion of patients for whom this means stopping corticosteroids and still maintaining complete disease control. And I think that is really a very nice and very promising message, because there's still a lot of developments in the field. And so I think the years to come are going to be happier and happier in terms of the perspectives for new treatments for these very complex diseases. And with that, my presentation is over, and I'd happy to answer any questions or have discussions about what I just presented.